it's Dr. Nelly here. We're going to brushing up on, yet again, we're talking about mouth breathing. And with me here, I have my friends.
Hi, Dr. Nelly. Nadia Afzal, general dentist with a passion for airway dentistry with a collaborative approach from Lehigh Valley, Pennsylvania.
Welcome.
Thank you.
Thank you so much for joining us.
Hi, Nelly. It's an honor to be here. My name is Dr. Shehzad Malik. I'm a board-certified cardiologist practicing in Allentown, Pennsylvania.
Fantastic. Thanks for joining me.
Thank you so much for having us.
So guys, just the other day I had a patient come by referral from another doctor, and the patient, I'll tell you a list of his chief complaints or his symptoms. TMJ noise, nervousness, insomnia, difficulty chewing, inability to focus, snoring, nasal congestion, posture problems, and acid reflux. I mean, those are lots of symptoms.
Wow.
Yeah.
And how old was he?
30.
Wow.
He's 30.
So he's lived that long with these symptoms.
Yes, yeah.
That's amazing.
So Nadia, talk to me about your approach in treating patients with mouth breathing problems.
Yeah, so I mean, we see patients like this all the time, Nelly, right? And I think oftentimes as dentists, before we would look at things just with one view, just what was inside the mouth and the teeth that we eat with, that's it.
Yeah.
But we would hear these symptoms all the time, and as I started delving into what's going on behind all this, I found that we actually have a big part in helping our patients. But it takes a lot of multi-factorial approach towards treating these patients with other providers. So it's a collaborative way to look at treating these patients. I would like to do a full exam. We look at everything, and then we see, okay, well, what are the pieces of the puzzle to make this patient healthier? When did these symptoms start? Obviously, this didn't happen overnight. It may have manifested at a younger age, but because we compensate so well, it was just never picked up on. So these things happened over time. And now they're presenting as this patient to you now with major problems that it's affecting the quality of life.
And you're right, we're talking about quality of life. Dr. Malik, talk to us about what you see from a cardiology perspective. Younger patients with these symptoms going on to have heart issues, I would imagine. Talk to me about what you see in your practice.
So in cardiology, we deal with people who have fallen on the other side of the spectrum: heart attack, stroke, congestive heart failure. Just below that spectrum, hypertension, diabetes, obesity, inactivity. Before that, it's everything related to common causes: nutritional disorders and sleep-disordered breathing. Sleep-disordered breathing is by far probably one of the biggest epidemics in the world today. It's a hidden epidemic because it's simply just not recognized by the majority of practitioners, particularly people in my field. And that's why we're here to sort of change that picture by addressing that topic.
I certainly would agree. I certainly think that it requires a number of doctors looking at the same thing, at least communicating and staying on top of our patients so our patients can have the best care. You know, patients like this, when they come to see me, I certainly look at it from an airway perspective as well. I think that from an airway perspective and a TMD perspective, it certainly overlaps. We see patients that have tongue tie causing the mouth breathing aspect. And when they are tongue-tied, they have a lot of neck issues. And that neck issue actually refers to jaw joint problems, as we see in our patient here, posture problems. So, you know, a lot of our patients in my practice are coming from a TMD aspect as well. So which one comes first? It's like the chicken or the egg.
Right.
And I think it's always good to start with an airway viewpoint and then kind of work from there. So I think moving ahead in helping our patients, cardiology is so important. My mom, you know, passed away. She had congestive heart failure, and she had a stroke. And I think a lot of those things, if they would have been caught early, we can start to get ahead of that inflammation causing these problems. So yes, so my patient here hasn't seen a cardiologist. So I think it's so great that my patient was able to find me through another provider. And so I was able to help him at least get in the right direction to evaluate him. So patients that come to see me, and I'm sure your practice too, Nadia, getting a CBCT, we want to see what the anatomy of the nose looks like, because before we were looking at just a sleep study.
Right.
We know that it's so much greater than putting an oral appliance in a patient, or let alone a CPAP for that matter.
Yeah, so the CPAP we know is the gold standard to treat sleep apnea. An oral appliance can be used when a CPAP is not tolerable, but we have to remember that both of those are just treating the symptoms, but not the underlying causes. And I think as practitioners, we have to do better by our patients, right? So we, as general dentists, are in the unique opportunity to provide longitudinal care for our patients. So we see patients from when they're 2 to 3 years old until they're well into their 90s. So we can see the cycle, the growth pattern, right? And we can see different stages of a problem occur. So this patient, I'm sure, probably had some level of restriction of his tongue at a younger age that was missed because he was able to compensate, didn't have good oral myofunction of his tongue.
And really quick, before we move forward, let's talk about myofunction. What exactly is myofunction?
So myofunction is the way that we rest our tongue in our mouth, okay? And to have good oral myofunction also can depend on how restricted our tongue is. So when we talk about, now the new catchphrase is, right, like tongue tie release. We hear a lot about that, about people going in and getting their tongues clipped for a variety of problems, right? But I think what we have to understand is that the tongue tie release, or the frenectomy as we call it, is really a way to help facilitate the oral myofunctional therapy. And the therapy is what actually can help develop better maxillar mandible growth of the jaws, which are our upper and lower jaws, help to expand it so we can have a wider airway, help get our tongue in a better resting position. So when we're sleeping at night, our tongue should be resting on the roof of our mouth. And for many people, it's not. And when the tongue is not resting on the roof of our mouth, we're probably sleeping with our mouths open, right? So it can help with a variety of things, but it goes back to saying, well, we can't just look at one thing and say we're going to just do a frenectomy and that's going to take care of the problem. No, we have to get an oral myofunctional therapist involved, and they take the lead on that, and we help facilitate them. And that's the same thing, like, when you go in and you see I'm sure this patient, you probably looked in his mouth and you probably saw that he had a narrow, high maxilla.
Yeah, and actually he does.
Right?
Yeah.
So how did that happen? His tongue couldn't get up there, to expand his maxilla. He probably could have benefited from expansion when he was younger, right? So he missed that opportunity, but now you can treat that, right? You can still do skeletal expansion as an adult, and it's one way to treat it.
Yep.
If he doesn't want to do it, there's other things we can do, but it's nice to know that sometimes you can take all these treatments, put them together, and really get to an ideal outcome.
Yes, and I see that in my practice all the time.
Yeah.
And I think the beauty of working together is that we can all communicate. I sent a report to this referring doctor, and I think that's key in making sure that the care just continues from that point on. So, as far as moving forward, I think it's so important that our patients understand that we want to breathe clean air through our nose. I mean, that's what our nose is designed for. And also, we want to eat with our mouth and not breathe through our mouth. I think that's the key component. In dentistry, we want to make sure that there's no decay. We want to make sure that there's no gum disease. I see in my practice that patients are constantly getting recurrent decay. They're constantly getting inflammation in their gums. And I think that our patients should have patience with us. We have a lot of questions and we want to know a lot of it, But general dentistry is no longer general dentistry anymore.
Right.
We are airway dentists, and I think that's the beauty of what we do. It's no longer about teeth. It's really about the overall health of the patient. So, Nadia, the big controversy is when to do tongue tie and if to do tongue tie on infants, right? We know that it's important because, I mean, I have a little one and I had challenges breastfeeding, and sometimes it's always the mother that is the cause of the lack of breastfeeding. Talk to me a little bit more about that.
So it's really interesting. A lot of mothers will know about tongue tie from their babies because they had a hard time nursing. And so a lot of lactation consultants will say, well, maybe your child's tongue is a bit too tethered, so we need to get it released. But babies can also compensate, right? So they can still nurse, and they might have a level of a tongue tie that may not be picked up right away, right? But it can lead into like they're breathing with their mouths at night, or as they get older and they're in their toddler years, they're waking up frequently. Restless sleepers, right? So it's important to have the baby evaluated if you have any trouble nursing for a frenectomy, because by setting your child up to be a good breather at night and in the day through their nose, not through their mouths, you're preventing them as they get older developing an issue where then they have to see someone like
Yeah.
And it starts as a child, it starts from the beginning. In 2004, Reggie White, the greatest defensive end ever to play the game, had to do that, just do that, of the Philadelphia Eagles, passed suddenly, was rushed to the hospital, found dead at the age of 43, died prematurely. He was diagnosed with a cardiac condition called cardiac sarcoidosis, which is an inflammatory disorder, but on his autopsy was sleep apnea. And his wife, who speaks for sleep institutes across the country on education regarding sleep apnea, she could tell you that he had an obvious problem at night. He snored, he stopped breathing. Maybe he had a CPAP he didn't wear, who knows? But we know sleep apnea contributed to his early demise. But this became a double-edged sword for the medical community. On the one hand, we became very adept at identifying men who were overweight, who snored and then would have resultant sleep apnea and could possibly die from it. On the other hand, we forgot that a woman can have sleep apnea, a child can have sleep apnea, a man who is not overweight, who doesn't have to have a thick neck, can have a severe sleep disordered breathing problem. And that's what we're noticing in our practice, is just the sheer amount of sleep disordered breathing across the board. So the statistics in our practice show that by the time you come see me as a heart doctor, and I'm no different than any other heart doctors, the statistics show that there's a 90% chance that you have some sleep disordered breathing, 40% chance that you are in the severe category, and that's astronomical.
Yeah, there was just a study at NIH where they studied insomniacs, and they found that 90% of those patients in that study had some level of sleep disordered breathing. I mean, we see it in kids, we see it in adults. I mean, I think it's just a broad spectrum here, and I think it really requires everyone from the dental community, from the medical community, to communicate.
Correct.
yes.
This specialist that referred the patient to me, I sent him a report. So he knows what I'm doing, and the patient's aware too, because the patient gets a copy of the report as well. So we want to make sure everyone's communicating.
Yes.
And I think that's pretty much the easy part of it. Guys, thank you so much for joining me. We've talked quite a bit.
Thank
We
you
talked
for
quite a
having us
bit.
here.
Thank
Yeah.
you so much. Guys, we just brushed up on mouth breathing. So till next time, I won't tell you what the next topic will be because I want you to tune in. I'll see you guys. Take care.